Now to the next session, which is actually a co-presentation, and we'll be talking about advancements in diagnostic imaging. We'll have three speakers for this session, and the first will be Dr. Milani, and then I can introduce our other two speakers, Dr. Miller and Dr. White. And so this session will be on immunohistochemistry, mass spectrometry, as well as new imaging and different approaches for amyloidosis identification and diagnosis. So Dr. Milani, again, thanks for being with us, and look forward to your presentation.
Okay. Thanks again. So next one, please. I will cover next one. I will cover immunohistochemistry and proteomics. So the biopsy part of this talk. I hope that there is no so, and these are the scenarios that we have. So we have obviously in all, as I mentioned before, in all patients with suspect AL amyloidosis, we need to have the amyloid identified and typed with a biopsy. A second scenario that has to be tested for biopsy is the scenario of patients with a grade 1 scintigraphy uptake, because these patients are at risk of having AL amyloidosis or having other types of amyloidosis, or also are at risk of having other cardiomyopathies. Obviously, the third scenario is the presence of a grade 2-3 scintigraphy uptake and a monoclonal protein, as mentioned before. So in all patients with a TTR probably monoclonal protein, so 30% of patients with ATTR need to be tested with a biopsy-proven approach. And lastly, obviously, in all patients in which we suspected another type of amyloidosis, a rarer form of amyloidosis, that we do not have to forget the presence of other types of amyloidosis. We had recently a couple of patients with cardiac AA amyloidosis based on cardiac biopsy, but we were not expected these kind of results. Next, please. So our approach in Pavia, as mentioned, is twofold. So for all, next, please. The first biopsy site that we suggest next, please, that we suggested for all patients is abdominal fat aspirate. Abdominal fat aspirate is an easy procedure. Also, punch biopsy can be used, and salivary gland biopsy is another important a so-called surrogate site for the diagnosis. Are both surrogate, but I don't like this word. I used to say that are diagnostic site for the diagnosis, because for both ATTR and the AL amyloidosis, if we have amyloid deposits into the fat aspirate or into the salivary gland biopsy, we can reach the final diagnosis with a correct typing. Bone marrow is also an important site, because obviously in all those patients who receive a bone marrow biopsy because of the monoclonal gammopathy of determinate significance of a smoldering multiple myeloma, amyloid deposit can be found and needs to be typed, because also at this site we may have TTR deposits in the bone marrow. In the patients in which all these biopsy resulted as negative, involved organ biopsy is required and typing is required. Next, please. Immunohistochemistry is obviously the best, the first, can be used as the first option, but the lack of sensitivity of the commercial antibodies needs to be considered. And so the guidelines, the International Society of Amyloidosis guidelines, suggested the use of custom-made antibodies that can reach the highest sensitivity. So we have to suggest to don't use the commercial antibodies for this technique. Next, please. If you cannot use custom-made antibodies, we may consider to use immune electron microscopy. The difference is that with immune electron microscopy, we can see the fibril and then we can see the antibody attached to the fibril. And so we can confirm if the amyloid is present and the type of the amyloid is present. The cons related to the use of both the techniques is the fact that we may consider only few types of amyloidosis, those types of amyloidosis for which we have specific antibodies. But obviously, not for all the types of amyloidosis are available. And so and next please. And this is an example of what I was saying. So the low sensitivity of the commercial antibodies, as we can see, all in the bottom figures, all appears as positive, but only one is positive, as we can see with specific antibodies due to immunohistochemistry. Next, please. For those patients in which we suspect different types of amyloidosis, or if for those who have the facility to use proteomics, this is probably the gold standard, because with proteomics we may find any type of amyloidosis. We may study the proteome of amyloidosis, so the different characteristics of the amyloid fibril. The cons related to this method is the higher cost and the fact that we need an expertise for the preparation of the sample and for the analysis that is specific related to proteomics. Next, please. Two are the options. An option using the whole tissue, as we use in Pavia on abdominal fat aspirate. Here are some examples of the samples of the abdominal fat aspirate that we are using in our clinic for the diagnosis. We can see really tiny amount of samples can be used for typing. And on formalin fixed paraffin embedded samples, thanks to the laser capture microdissection that was proposed by the Mayo Group, you can reach the same sensitivity where you can identify and type the amyloid deposits as well. Next, please. In our approach in Pavia is now to perform in all cases of positive Congo red abdominal fat aspirate, a sample for immune electron microscopy and a sample for mass spectrometry. And next, please. And this is our flowchart. The sample is prepared, washed, in order to avoid blood contamination. That is the main issue for this situation, and then analyzed in the Orbitrap mass spectrometer, and then the final amyloid fibril is identified. Next, please. Thanks to this method, we were able to type almost more than 400 patients now, with really good results compared to our standard technique, that is immune electron microscopy. We have few cases in which we were unable to type with mass spectrometry, but the diagnosis was confirmed by immune electron microscopy, and the opposite. So few cases in which the diagnosis was reached by mass spectrometry and not due to immune electron microscopy. This is probably mainly due to the fact that the sample is tiny and different. So I really believe, next please, that typing of amyloid deposits is mandatory, and immunohistochemistry is a good option, but only if you use custom-made antibodies. Immune electron microscopy can be a good option and is our standard procedure, but proteomics on the whole tissue in fat pad and with laser capture microdissection remain the gold standard for proteomic studies. And with that, I I stop here. Thanks.
Great. Thank you again, Dr. Milani. That was another fascinating presentation, and thanks again for your insights. So we'll move on to the next presenter for this session. It's my pleasure to introduce Dr. Robert Miller. Dr. Miller is a cardiologist in Calgary who also attends in our cardiac amyloidosis clinic and also is a nuclear cardiology specialist and expert and is going to give us an update on advancements from that field. So thanks very much for being with us.
Thanks for the intro, Noel. I'll get right into it because I have a lot to try to get through in 10 minutes. I do have some disclosures that are relevant. I do receive some grant support from Pfizer and Alberta Innovates. So there's tons of imaging opportunities in cardiac amyloidosis, and we all know that echo is a good way to screen for cardiac amyloid, and there's specific patterns that you can look for. And certainly, like MRI gives the best pictures by far. So hard to downplay the importance of CMR, and certainly James is going to cover really the strengths of CMR later. But when we're talking about nuclear, people really focus on these planar images from pyrophosphate scans, and that's because it's really easy to interpret. Either there's uptake or there isn't. And the first study to look at this was described by Pergine et al. You can note only 45 patients. Not a big study, certainly not what we would consider high quality evidence, but was the first study to describe this, and they demonstrated that pyrophosphate imaging had very good diagnostic accuracy. However, what we know is that the patients sent for pyrophosphate imaging have changed over time. So this is data from Columbia looking at the proportion of patients that have grade 3 uptake. And what you can see is that proportion has decreased significantly over time as the green bars, which is number of tests, increase over time, but really no significant change in the number of patients requiring biopsies. And that's because pyrophosphate imaging works really well. So this is, again, a planar imaging that people could call grade 1 or grade 2. People sort of had difficulties distinguishing them. So like all good nuclear cardiologists, they decided to draw circles because we like to draw circles. So they drew a circle on one side and the other and said, well, there's these ratios that seem to work pretty well at distinguishing people with ATTR from those without. Unfortunately, this really doesn't work that well. And that's because really the question is, like, where is the uptake? So instead of these 2D pictures, it's really important to think about 3D pictures. So this is SPECT rather than planar. And here you can see that the uptake's clearly in the heart. Here you can see that the uptake's clearly not in the heart. And that's where pyrophosphate imaging is really helpful. Because if you talk about echo and CMR, they're good at saying, well, there is some amyloid maybe, where pyrophosphate really answers the question, is this ATTR, is this not ATTR? When you compare planar and SPECT imaging, you can see that there's differences. So this is work put together by Dr. Masri, where he looked at the planar visual grading, which is the vertical axis, compared to the SPECT grading, which is the horizontal axis. And you can see that there's not good agreement between the two. There's certainly some overlap. And similarly, if you look at HCl ratio, you can see that there's actually a split between people who are SPECT positive and SPECT negative, but quite a bit of overlap. And what's really upsetting is if you look at the old ASNC guidelines, they used to say, well, this box is equivocal. So it used to be 30 to 40% of cases would be equivocal if you use the HCl ratio. Whereas with SPECT imaging, you can clearly tell where the uptake is, so you can take these equivocal patients and make them either positive or negative with maybe close to 1 or 2% equivocal instead of this 30 to 40% equivocal. So this is really where pyrophosphate imaging has transitioned towards saying, yes, it's there, or no, it's not there, and all based on the SPECT imaging. So ASNC did release an addendum to their guideline changing how to interpret pyrophosphate imaging. But there's also a lot of exciting things that could be done with the SPECT imaging that is sort of a work in progress. There's different ways to quantify this. And again, the underlying rationale is nuclear cardiologists love to draw circles. So our question was, where can we draw circles? So this group looked at different uptake ratios where they drew circles over either the myocardium or various reference backgrounds. And what they showed is that the diagnostic accuracy, here showing the AUC curves, for these uptake ratios were really good. Dr. Dorabala's group, who's at a Brigham, decided to draw circles on the CT scan instead of the SPECT imaging. And then they quantified everything inside those circles. And again, showed that the more uptake you had within these circles, the more likely you were to be positive. They went on to show that these quantitative metrics varied significantly by patients with and without ATTR. We also like to draw circles, so we just drew them slightly different way. So we draw a white circle for background to figure out how much radiotracer is in the blood pool, and then a different region of interest over the myocardium, and then quantify everything that's above background. And we developed these two metrics called volume of involvement and cardiac pyrophosphate activity. And we showed, again, very good diagnostic accuracy. But truthfully, it's not that hard to interpret a SPECT pyrophosphate scan. Like either it's positive or it's negative. People are really good at doing this visually. So we worked on a different approach to try to make it more clinically relevant. And what we used is this segmentation deep learning tool that segments out different organs. And we said, well, that's great. Why don't you segment out the cardiac chambers from these pyrophosphate scans? And we used that to derive the same background and region of interest over either left atrium or right atrium for backgrounds and the myocardium for the region of interest. And this is what it looks like when you apply this to an actual case. So as you can tell, that this case is positive, so you can see that there's myocardial uptake throughout the left ventricle. And when you quantify it, it's quite abnormal. This is a case that's negative, so again, you can see that this nice LV region of interest really avoids all that blood pool, but you still get good blood pool signals from the other regions of interest. And again, very good diagnostic accuracy here in almost 300 patients. But more importantly, it's associated with risk. So here, looking at the different quantitative metrics, and we adjusted for age and sex, and you can see that patients with higher quantitative values were more likely to experience the combined outcome of either cardiac death or heart failure hospitalization. So certainly more work to occur in the quantitative aspect of nuclear cardiology. The other direction nuclear cardiology is going is in PET. So there's different radiotracers that are available for PET. This is work from Sarah Cuddy looking at Fleur beta Pier, and you can see that patients with active cardiac amyloidosis have uptake through the left ventricle. Patients without active cardiac amyloidosis don't. The interesting thing about Fleur beta Pier and the other PET radiotracers is that they're pan-amyloid tracers. So they're taking up both an AL and ATTR cardiac amyloidosis. Maybe that gets away from the strength of nuclear, which is differentiating the ATTR patients, but that is something that could be debated. Here they showed that the retention indices for these different metrics were higher in patients with AL cardiac amyloidosis. And it can maybe help you distinguish people with active AL cardiac amyloidosis from patients with either remission or not active cardiac amyloidosis. As I mentioned, there's many different radiotracers. One that's getting a lot of press right now is evuzametide, and that's because it just published its initial data. Again, this is a radiotracer that's a PET radiotracer, but binds to any type of amyloid. And what you can see here is just different examples of uptake, either in patients with wild type or hereditary ATTR, as well as AL cardiac amyloidosis. And you can see that, again, it really just shows where the uptake is. So it's a way to detect any type of amyloid, which is, again, something that might be relevant and potentially a way to get away from biopsying all of these patients. So I tried to cover a lot in a short period of time. I know there's a question period at the end.
Thanks very much, Dr. Miller. And yeah, we'll open it up for questions at the end. But that was a great presentation, and I'm glad to see that with all those circles, we're not just going in circles. So sorry, I can't resist a bad pun when I see one, as Dr. Miller is very aware. It's my honor again to introduce our final speaker for the session, Dr. James White. Dr. White is another friend and colleague and is a cardiologist in Calgary who I've known for many years. Dr. White is a cardiac MRI specialist and was the director of our cardiac MRI center in Calgary, and is also now the director and leader of our precision medicine program at the University of Calgary. My pleasure to introduce him, and thanks, James, for being here. Look forward to your presentation.
Thanks a lot, Nolan. Thanks for the invitation. Really appreciate it. All right. Can you show my slide on this one as well, so I don't have to keep turning? And pointer. This one? Okay, great. All right. Well, I'll look up here for now. So I do have a couple of disclosures to put up there. You're able to get it on this screen because I actually can't see it on that screen very well. So as Noel introduced, I'm a cardiac MRI specialist, and so I'm going to be talking specifically about cardiac MRI in the role of detecting and monitoring cardiac amyloid. And as Noel had pointed out earlier in the talk, many patients with amyloid end up getting a myriad of tests because it's a multi-organ disease and it's indolent, and a lot of time is spent trying to figure out if it's there or not. So we're not going to talk about all the different types of tests that we might be able to pick up amyloid. We're going to focus specifically on the role of high-quality definitive testing with MRI to be able to elucidate whether or not cardiac involvement is present or not. So I'm really focusing just on one aspect of diagnostics. And the first thing to explain is just what is MRI. And cardiac MRI is really a technique that leverages the fact that you are full of little magnets. And so your body is made up of about 7 billion protons. Protons are little magnets. And so just like the Earth, they've got a north and a south pole. And so when we put them inside another magnet, we have the advantage of being able to start to control those little magnets. And they actually spin at a specific frequency that we can then send in radio frequencies to resonate with them and make them dance. And dancing is a great thing because you can dance in many different ways. And so we can generate many different types of images with MRI. And so the advantages of MRI are really around the fact that there's no radiation at all. Not that radiation is always a bad thing, and certainly it's we have to keep that in perspective when we're talking about radiation risk. But MRI is very accurate, and so it has high reproducibility and fidelity, and so it allows us to measure things down to very finite points where we can track them over time. And that has really unique advantages, especially as we'll get to later. But the other thing is versatility. Because we can make your protons dance in so many different ways, whether it's a cha-cha, whether it's the waltz, it doesn't matter. The way that we can do that means we can get a very broad range of different images, all from one test. And I'm going to show you some of the ways that we can do that. So starting out with what we call cine imaging, which is taking movies of the heart moving. We can look at the heart in any different angle we want. So there's no limitations to image quality. We get very high image quality. And we can look at the heart chambers to see if they're increased in thickness, whether there's contractile dysfunction. And we can get a lot of information about things like heart valves as well. But the real advantages of MRI is that we can give contrast, and there's both intrinsic contrast and exogenous contrast. We'll talk about that in a second. This is where we've given an exogenous contrast. We've given you something called gadolinium, and what it does is highlights all the areas where there's no cells, basically, so all the extracellular space. And that is a space that amyloid likes to sit in. And so as amyloid protein deposits within the cells or around the cells, it expands that space and allows for gadolinium to sit there. So we end up getting a marker from the gadolinium enhancement as to where amyloid protein is. And in the heart you're seeing here, which is not a particularly thick heart, it was actually missed by echocardiography as being amyloid. You can see it lights up like a Christmas tree, with all the bright areas being areas where amyloid is deposited. And the heart muscle should be black on that lower image, and it's all bright white. But increasingly, we've got some more advanced techniques that instead of just visually looking at images and saying, is it there, is it not there, we've actually got tissue mapping techniques now that we use broadly. And these are quantitative techniques that converts each pixel of the image into a quantitative measure. So I can actually measure the pixel, and it tells me exactly how much of a specific marker there is. And there's two markers that we use. One is called T1, which is intrinsic to the tissue itself, and I'll describe it in a second. And the other is the actual extracellular volume. So we can measure how much the space around cells is expanded. And that's directly proportional to the amount of amyloid in the tissue. So just to go through some more advanced and emerging techniques, so at the top here you can see that there's the ability, similar to echocardiography, to look at those movie images and actually measure or quantify the deformation of the tissue. And that's something that we call strain. This is a really valuable marker, especially given the quality of the images from MRI, to be able to track the health of the contractile health of the muscle. And that is something that we can use to monitor the health of patients to see, are they responding or are they not responding? We can also do this now in 4D techniques, so we can generate four-dimensional models of the heart from the same images and use those to actually detect and track improvement in heart function. And one of the things that we're looking at is actually using it to be able to differentiate between AL and ATTR amyloid, which is something that Rob mentioned is very challenging to do by MRI. And so we're trying to figure out ways that we can do it too. And it turns out that the deposition of the proteins and the distribution of them does change between the two, and there are features that we can look at to be able to figure out which protein we're dealing with. But I did mention that tissue mapping has now become a very exciting field for MRI, and we use it to get very accurate measurements of heart health. And just to kind of describe how that works is that I mentioned when we put urprotons inside a magnet, this being a very big one, they line up and they start moving in a way that we can actually control. So I can actually put a pulse and make them turn 90 degrees, and then they'll recover and they'll come back up. So if I do that again and we measure the time that it took to come back up, that's called the T1 recovery time. And that is unique to every single tissue. And it turns out that when amyloid protein is sitting in a tissue, it takes a lot longer for that to happen. And so we can create images that are encoded with that value for every single pixel. And that correlates with the amount of amyloid protein that is there. Now we can do that before contrast, which is basically what you're seeing on the top part of the screen, which is the amyloid protein deposits. It increases that time, and we can measure it by drawing a little region of interest. But we can also then give gadolinium, and that gadolinium, remember, is going to all the spaces that amyloid sits. So if you subtract the two now, you can actually estimate down to a percentage point exactly how much that space is expanded because of the protein. We call that ECV, or extracellular volume. And in this patient here, it should be around 25 to 30%, and I believe, I can't see it, but I think it's something like 70-something%. So a tremendous amount of amyloid protein burden. So we can use this to track response. And then finally, we've got the most long-standing and broad evidence has been provided by late gadolinium enhancement imaging. And this is after about 5 to 10 minutes that we've given that gadolinium, we can get these images that tell us a distribution of how much protein is likely in the tissue by the amount of contrast that's there. And this has been shown to be correlated to both amyloid protein deposition histologically, but also in patients, and this was published about 10 years ago, if you show this pattern of diffuse uptake, you ended up having a very, very poor prognosis. But that is all before the age of targeted therapeutics. And so since this paper, there's been 10 subsequent papers or more that have shown, yes, indeed, in that history, and it is historical now, that in the age where we did not have these disease-modifying agents, it was very, very bad when you got this diagnosis. But now we're in an era like this, where we see cases that are really just transformative. And so on the top, this is a patient at our institute that had AL amyloidosis, and after one treatment cycle, ended up getting complete resolution of their late gadolinium enhancement, and their ECV dropped by 20 points. I've never seen this. So I've been reading cardiac MRIs for close to 20 years now. I have never, ever witnessed this, that we thought that this was a permanent feature, that once you've got all this amyloid in the tissue, that's it. But this is actual resolution. I've never seen this before. And on the bottom, we're seeing increasingly evidence that supports that with these disease-modifying agents for ATTR, that we similarly can see definite stabilization, but in some cases, regression as well of the ECV. And so I think this is a really exciting time. So finally, what is the value of cardiac MRI in this disease? Well, the first thing is, and I'm going to try to read it from here, prognosis. Is that diagnosis or prognosis? Diagnosis. Okay. So MRI has the ability to detect the presence of amyloid, but also compare it to other diseases. So if you're unsure what disease you're facing, then it's going to be able to tell you, is this amyloid or not? But if it's something else, we can also give you a diagnosis. So if it's hypertrophic cardiomyopathy, if it's hypertensive heart disease. But also, certainly, because of the era of pyrophosphate imaging, we are not the go-to first test anymore to tell you that ATTR is present. That is pyrophosphate imaging. We may be able to do that in the future, but it's not our role. Our role is really to give you quantitative measures that are accurate and reproducible to follow how much amyloid protein is in the system and is it changing over time. I think our quantitative measures are good for that. And then finally, in prognosis, we've got to reestablish prognosis in amyloid. It's so iterative and changing dynamically now that we need very highly accurate markers so that we don't need thousands of patients to develop these prognostic markers. We can do it with relatively few because it's very reproducible. MRI has a unique ability to deliver that. So thank you very much.
Great. Thanks very much, James. And thanks again to all our speakers for that fantastic session on advanced diagnostic techniques. We do have some time for questions or comments from the audience. Any questions? I have a question over here. Anne-Marie.
Good morning. Thanks very much for those great presentations. They were fabulous. I've got a question for you, Dr. White. Can someone with a pacemaker or a defibrillator, would they be able to have this type of treatment done? And secondly, to that, where can this be done? Is it basically just Calgary, or are there other sites available?
Yeah.
So a bit tongue-tied.
So fantastic question. So to answer your first question, the answer is that no, things have changed quite a lot over the last 5 years. And so we used to be quite concerned about putting people with pacemakers and other devices into the MRI machine. Increasingly, what we learned is actually quite safe. And so even for patients with historic non-compatible devices, we actually can image those people at 1.5 Tesla. We just follow a protocol. Any of the obviously compatible devices can go into the MRI scanner. The only thing to be aware of is that sometimes it does impede the image quality a bit. And so when we're trying to do accurate measurements, especially for like those ECV measurements, we can't rely on them as much, but at least it allows us to still use it as a diagnostic tool. With respect to availability, so most academic centers now across Canada, in fact all, do have cardiac MRI services. That doesn't mean to say that you can get it quickly. These services are limited supply, so in Calgary we're blessed by having 2 dedicated facilities. We're one of the busiest services in Canada. Toronto also has good resources. Other centers may only be able to do very few, and so the wait time can be substantial. And so you really need to look at it from a regional perspective. For most centers like Toronto, Ottawa, Calgary, BC, we can support a certain amount, and usually amyloid is prioritized relatively high, but it can be a bit of a challenge.
Yes, thank you for nice presentation. My question actually, if we have suspicion of cardiac amyloidosis by cardiac MRI, but not diagnosed by BYB scan. So what's the rule here? So because there is discrepancy between MRI and BYB scan.
Yeah, so I mean, the first question is it AL, right? So that's a very common scenario that it's AL amyloid, so the pyrophosphate's negative. We have had some discrepant cases, though. And so sometimes Rob and I are called in to kind of battle against each other. So, you know, his pyrophosphate scan may look more negative and my MRI looks more positive and vice versa. And so I think that there are fringe cases, always. Sometimes I would say that the situation has been more that the pyrophosphate scan has been more sensitive and that the MRI hasn't been interpreted quite as accurately. And so he's usually right. But that's because sometimes it's very subtle. And MRI tends to be very specific and maybe not as sensitive. And so I think that there are fringe cases, and that's why you need experts to come in and really arm wrestle. And he wins. Yeah.
So the other scenario that's important is there are a couple hereditary causes of ATTR that can be PYP negative.
Yeah.
They tend not to be the most common gene variants, but there are some variants that can be PYP negative but CMR positive. So in some of those borderline cases or fringe cases, like genetic testing can be quite helpful in helping to adjudicate.
It's Chris Fenner again. So one question I have is with respect to the quantitative capabilities of all of the imaging that you guys very nicely presented. And you had alluded to the fact that we can follow the disease, but are we at a point, both for ATTR and for AL, where we need to really start to standardize that? And I don't know if Dr. Milani is on, but this would be also a question for him as more on the hematologist side of things. And if so, what is your sense as to the rate of change? You showed a beautiful case, and clinically we see quite a bit of heterogeneity. But at some point we have to sort of develop some guidelines. Is it going to be a once-a-year scan, once every 6 months? Or do we take a bit more of a pragmatic approach and look at biomarkers as our gauge as to when to re-image, or even the clinical history?
Well, I was actually going to just add to that as well, and maybe we can hear from Rob and James. And you know, I would never guessed that we'd be seeing resolution of amyloid burden, as you showed, and we're seeing more and more examples of that. And the timing of that can vary. You know, often it takes a few years, but you know, the cases I've seen after a couple years, or sometimes several years, are really dramatic and exciting. And so, and another one of to expand on Dr. Venner's comment as well, you know, one of the challenges is recurrence, particularly in the AL population as well. It's very difficult sometimes to judge, especially for cardiac, but not just for cardiac, when there has been recurrence of AL, and we kind of look to imaging. So I wonder if you could, maybe this is more directed to James, address Chris's comment about ongoing follow-up and standardization of follow-up, and as part and parcel of that, assessing for improvement and assessing for recurrence, with both modalities for, you know, LGE and T1.
Yeah, so I mean, I have two hats that I can wear on that one, an academic hat and a clinical hat. I mean, from an academic standpoint, I want to do MRIs on everybody serially, right? I mean, it's obvious, but there's a very pragmatic side to this that's just not feasible. And so I think what we need to do is probably rely a little bit more on our routine biomarkers and develop, and which has been done, you know, standard risk scores that we can use to be able to track response. And, you know, obviously listen to patients and see how they're doing. But I do think that what we've established in Calgary is that patients are getting annual cardiac MRIs. We are looking at that data, and we're trying to understand whether or not that frequency is required. We're seeing that there's fantastic stability in, with the addition of tafamidis, patients have stabilized incredibly well with respect to their imaging markers. But how long do we need to keep going? Are we going to keep doing MRIs every year for the next 20 years? That's a very, very good question. And I think that there's probably a point where it does make sense.
Yeah.
I think that we probably will be able to rely more heavily on other imaging markers as well. I think that following patients by strain using echo is actually quite valuable if it's done properly. And then also the question of whether or not, and I'm going to let Rob speak to this, that doing quantitative assessment by pyrophosphate is a very reasonable approach as well, because we're seeing quite a lot of congruence between MRI and pyrophosphate changes over time.
Yeah, thanks, James. And just to expand on our Calgary approach, not that it's the right approach necessarily, of course, but we do annual MRIs for patients who are getting active treatment for their AL. And if they come off treatment, then it becomes much more variable and clinically guided, and typically, we'll repeat the MRI if we're seeing changes in any of their other biomarkers. And we're still learning about, the efficacy of that approach, of course. Okay, Rob, other thoughts from the nuclear side?
Yeah, I think, certainly it's a really good question, and it's an area that evidence is evolving. So ATTR side is where nuclear has a bit more evidence, and certainly we see that people on tafamidis have decrease in quantitative metrics of PYP uptake. It is a little bit dissociated from some of the clinical features, which is the echo might not change at all. But then the question is really what's the right metric of disease burden, and that's sort of uncertain. So the one study that James did highlight is that work by Fontana et al. That looked at both CMR as well as DPD markers, and both decreased in response to patisiran in this cohort of hereditary ATTR patients. So there's lots of cohort studies like this showing that these metrics decrease over time. I'm aware of some similar data using evuzametide for AL patients, and certainly there's evidence for florbetapirin differentiating people with active AL cardiac from patients in remission. But those studies would be really tough to do serially because the PET agents are associated with actually significantly more radiation exposure than the SPECT agents. So I think it's really unclear in terms of frequency, and I agree with James that it's probably going to be other biomarkers that really trigger some of these more advanced testing that might help differentiate.
Great, thanks. We have time for one or two more questions. Question over here.
Hi. The contrast. If somebody is affected in the kidney, would the contrast create a problem for the kidneys?
Yeah, so that's also been an evolution over the last decade. So about a year and a half ago, we published new guidelines, Canadian guidelines for the use of gadolinium in MRI. And on that panel, we had lots of active discussion, but what we arrived at was the conclusion that the safety concerns are much less than they were before, and that's because we've got much more stable agents. So we've got now what we call macrocyclic gadolinium agents, much more stable and do not dissociate as much. And so now in patients that have what we call GFR, which is the function of the kidney, down to about 15, we will actually go ahead and give a macrocyclic agent. And that does still vary if you go to different units. And so sometimes radiology won't be as comfortable with those things. And so, from clinical standpoint, always ask for second opinions. But we also, if the GFR is less than 15, depending on the indication and in consultation with nephrology, we may still go ahead. It may be that the patient's on dialysis. But the bottom line is that since the FDA had its warning release, which is now almost 10 years ago, the number of cases of complications from gadolinium with a GFR of 30 or higher has been 0. And so what we're feeling is that we can now relax our concerns, and generally speaking, going down to a GFR of 15 is reasonable, provided that there's a solid indication for doing the test.
Thanks, James. Important question. Chris, you had another question. Yeah, sure.
One of the things that I've always wondered
have the ability to sort out the degree of stickiness of the amyloid based on the imaging. And that has, I guess, more to do with the ability of it to resorb over time. And the second thing is wondering about better ways to discern the damage to the, in this case, the heart, but I guess the question also would be in other organs where we could actually image that, where it may not be so much related to the raw amount of amyloid, but rather that extra layer of sort of biochemical properties that cause the tissue toxicity. And is that something that where we're at a point where we can start to look at some of that functionality of the tissues, or is it still more of a, quantitative kind of a modality, or modalities plural?
This is a really great question, and I think neither James nor I really want to answer it. So I'll do my best, and then James will correct me. So there's probably a role for multimodal information, so especially for the ATTR patients, like there's quantitative metrics from the pyrophosphate that correlate with amyloid, and there's things like ECV and T1 that correlate with amyloid and the scar. It's probably even more so the case with AL patients where we know there's some scar, there's some inflammation. And as James nicely highlighted, there's so many more things you can look at on CMR. So T1 and T2 and ECV and how these things change over time can really help you differentiate that. So that's what I default to in clinic is people ask me how much is amyloid, how much is inflammation, and I say, well, we'll find out in 6 months when we repeat it. But I think it's an area where we really don't know the best way to do this at baseline yet. There's probably a way to do it with multimodal information. There's probably a way to do it with CMR for the AL patients if you look at all of the different tissue characteristics, but I think there's more evidence is needed.
Yeah, I don't have a lot to add, really. I mean, so I think that I think with some of the newer agents that are coming out that are really designed to extract amyloid out of the tissues, I think that serially monitoring those patients and understanding the rate at which different patients actually get response is going to be very exciting. That might answer the question. And I do think that, MRI offers some quantitative tools to do that serially very nicely. But for ATTR, also pyrophosphate quantitation is good. So that's about it. I think, we'll have to wait and see. I did want to come back to the kidney question, though, because I think one of the things that I didn't mention is the fact that in patients with amyloid now, the reproducibility and accuracy of native T1, which is without contrast to be able to monitor disease, is actually very good. And so we often now do just non-contrast MRI using that technique and can have very high diagnostic accuracy just by looking at the native T1 values. So it's been very, very helpful.
Yeah, great. Thanks for your insights, both of you. Actually, I was going to ask almost the same question as Dr. Venner did. So, stickiness and organ damage and new deposition versus old deposition. So I want you both to work on that. And then next year, we want to hear back with your progress when we talk again. So, no, thanks very much to all of our speakers for this session, Dr. Milani, Dr. Miller, and Dr. White for an excellent session. And thank you all again. We have lunch now, so I'm sure everyone's hungry. And we're going to pick up again at 1:30 for the afternoon sessions. So have a good lunch, and thanks again for being here.